Okay, hello everybody. Welcome to our final YouTube lecture for IntroPsych, and this will be chapter 13 on mental disorders. And let's proceed. All righty. So, chapter 13 on mental health disorders. All righty. Um, for this chapter, we will talk about perspectives on how we construe what a mental health disorder is, or a mental disorder, or really the general issue of what is abnormal. Okay, how do we come to a conclusion that something is abnormal in terms of human behavior? Then, for this discussion, we will go through some of the major categories of mental disorders. By no means will we be able to go through all of them, right? There are about a couple hundred different mental disorder diagnoses, and they're all organized in about 17 categories. We're just going to go through some of the major categories, most common categories, and some of the more common diagnoses of mental disorders in those few categories that we have time to go over. But for those of you who have an interest in understanding abnormal psychology, I highly recommend taking that course. That course, which I teach, but I'm not the only one who teaches it here at HBU, goes over most of the major categories and most of the diagnoses within each category. And there's a whole bunch of ways in which we can experience abnormal behavior in human functioning. So, highly recommend that course. When I was an undergrad, it was one of my favorite courses, to take as a psychology major. The other one was social psychology. That was very cool as well. So abnormal, social psych. We have a forensic psych course, which I also teach. And maybe no coincidence that I'm bringing it up, which deals with how psychology assists the legal system, both in the courts as well as law enforcement. Yeah. And I think those are some of the really cool classes, go-tos for if you're not a psych major. Yeah. We'll kind of bypass this stuff. So let's look at some perspectives on mental disorders. Yeah. And first of all, to start a discussion, what is a mental disorder? Yeah, well, mental disorder generally describes a problem in emotions, thinking, and or behavior. Yeah. Now, what kinds of how do you determine whether something is a mental disorder? When we use the term mental disorder, we're talking about a condition in which there is a diagnosis. All righty, and we'll get into diagnosis in a moment. Yeah, but um, what qualifies something as being a mental disorder? Okay. Well, these are four major characteristics to keep in mind when thinking about what may be diagnosable. Yeah. First of all, is the behavior kind of unusual, atypical, not common? Yeah. So certainly, let's say hearing hearing voices telling you that the KGB is after you. Yeah, that's unusual. Most people don't have that experience. Alrighty. Those who are suffering from a psychotic disorder like schizophrenia may experience a symptom of that sort. Yeah, but the vast majority of us don't experience that phenomenon. Alrighty. But you can see already, even with the first of the four kind of categories of consideration, yeah, atypic, atypic, atypicality, right, is a concerning one because, all right, maybe hearing voices that the KGB is after you is unusual, right, which suggests you're suffering from a mental disorder. But maybe there are a lot of behaviors that people demonstrate are not par for the course, don't fit the norm, but are not suggestive of a mental disorder at all or psychopathology at all. Yeah, it just may be unusual, unique, or brilliant, or genius, right? That something someone is thinking, feeling, or behaving departs from the norm. Yeah, it may be a good thing, a strength. So this is where one has to be really careful with how one considers not only this factor, but the other three factors that I'm going to be going through now. Okay. Now, another thing is if the behavior is disturbing to the individual and or to others. Alrighty, so that's certainly of concern. Certainly, if the individual is distressed, all right, that raises a flag that they're suffering from a mental disorder. Okay, and also if it's distressing or disturbing to others. Okay, maybe even more so the latter situation though. We got to pause before considering something as a mental disorder because it's distressing to others. Yeah, just because it's distressing to others, yeah, it may be not because the individual is suffering from a mental disorder, but it may be a sociological issue. Alrighty, that maybe people don't accept a certain behavior, yeah, but just because society or others don't accept the behavior or find it distressing, doesn't necessarily mean that the person is suffering from a mental disorder. So that's an important one to keep in mind. Yeah, as an example, yeah, it's hard to believe this now, but there was a time homosexuality was considered a diagnosable mental disorder. Yeah, but it really raised a question, or it regrettably didn't raise the question sufficiently, but at a point it did raised the question of, to what extent, because it was disturbing to others, was that society's fault or the individual's fault? Yeah. And I think we became enlightened and realized that, one, it's not a pathology, it's not a mental disorder, but that maybe society was having a problem, struggling with a certain proportion, no small proportion of our population that is homosexual. Okay, so now it is not a disorder. I think it was 1977, American Psychiatric Association made the determination that it is not a disorder. Okay? But in general, and again, you got to just think about what is meant by disturbing. Okay, it is a good factor to consider, but it shouldn't be has to be taken without thought. It's not just a simple box you check off. Okay. The other consideration is whether the thoughts, feelings, and behaviors are maladaptive. Yeah. If they have, in particular, when it comes to adaptation, fitting with the environment. Yeah. Particular concern is whether it's affecting their social or occupational functioning. Yeah. So is it affecting their ability to make friends, date, right, find romantic partners, uh, uh, function in their families, and so on? Or occupational functioning, is it something affecting them at work, or if not works, things like school? Okay, so that's usually a good sign if it seems to be affecting social and or occupational functioning. All righty, but if it isn't, right, it may be atypical, it may be disturbing others, but if it's not affecting their ability to relate with their family, make friends, it's not affecting their performance in school and work, okay, you got to ask yourself if it's something suggestive of a mental disorder. Maybe not. Okay. And finally, whether the behavior, thoughts, or feelings are not justifiable. Okay. In other words, there's no clear external reinforcement for the behavior. Okay. So, for example, someone in a clown suit walking down 4th Street Mall, you might see that go, oof, a little concerning. Maybe that person suffers from a mental disorder. Alrighty. But if you later find out that they're going to an office party because they're hired by the office to be a party clown and entertain people because they're a comedian, then that's justifiable, right? They're being paid to do that, right? It's a job. But if they're just doing it because the mood strikes them, right, to walk downtown Honolulu as a party clown, might be suggestive of some kind of mental disorder going on. Okay? And here's a big consideration. Now, all of mental disorders are organized and categorized in what's referred to as the Diagnostic and Statistical Manual of Mental Disorders, or DSM. Alrighty? So there are different categories, about 17 categories of disorders, right? We have mood disorders, anxiety disorders, eating disorders, and within each of the categories, different diagnoses, right? So for like eating disorders, we have anorexia, bulimia, With mood disorders, we have major depression and bipolar disorder, among others. And each diagnosis includes several criteria, yeah, and a certain number of which the person needs to meet in order to be diagnosed as suffering from that condition. Alrighty, so like for depression, it may be depressed mood, right, or the inability to experience pleasure, right? And another criterion is that they need to experience their depressed symptoms for at least a 2-week period to be diagnosed as suffering from a major depression. Alrighty. But here's the big warning. Yeah. You got to examine those criteria carefully. And because some of the criteria are empirically supported, others not so much so. So that's the thing that the clinician has to kind of keep in mind. To what extent criteria were driven by research, empiricism, or to which ones may have been determined by committee or arbitrarily determined. Okay? Not without reason and an understanding of research, but some of the criteria are well reasoned and supported by research, but others aren't. They were based more on anecdotal experience or clinical experience, right, by committee members. So that's something that the clinician kind of has to keep in mind and be kind of mindful of. Okay. So I just discussed a little bit about the DSM, okay? And what's important to keep in mind with the diagnostic manual is that it describes clusters of symptoms. Okay, it's not an attempt to explain why someone may have major depression or why they have anorexia. Okay, it's a classification system to categorize major categories, list diagnoses within those categories, and then for each category, what symptoms characterize each diagnosis. So it's not an explanatory device, okay, or book. What is its objective? Its objective is to describe the different disorders, okay, in a way that they can be easily identified and diagnosed, or for treatment purposes, or for research purposes. The idea of having a diagnosis also is to allow the clinician, psychiatrist, psychologist, social worker, counselor, who have you, whoever is in the business of treating mental disorders, to predict, okay, how the disorder will proceed, maybe be able to determine a prognosis, right, a kind of a determination of how things will go, if the prognosis is good or poor, and also determine what treatments are relevant. Yeah. So because we organize all the different mental disorders by diagnoses, yeah, there have been research for most of the diagnoses, yeah, which have indicated things such as prognosis, course of the disorder, and treatments and course of treatment. All righty. So it's been immensely valuable for that purpose, for those purposes. Okay. A criticism of the DSM is that some of the criteria may be too broad. In other words, we may pathologize things or make things diagnosable, which aren't mental disorders. Yeah. A classic example is ADHD, attention deficit hyperactivity disorder. Yeah. Some of the criteria, yeah, which we won't probably be getting into in this chapter's discussion, may include childhood behaviors like getting out of your seat, being inattentive, difficulty focusing, and such, which may make it very easy to diagnose or overdiagnose a condition to children. Yeah, and there are other examples with other disorders. Okay. And as mentioned just a moment ago, many of the criteria that go to diagnosing someone are empirically supported by research, okay, and well thought out. Others may have been more arbitrary, more of a function of the because each of the disorders, right, each of the category of disorders, when the different categories were set up, committees are assigned to the different categories, and the committees did the work of determining the different diagnoses and the criteria for each diagnosis. And when determining that, a lot of it was done based on well-reasoned, empirically supported data. But others may have been more arbitrary, more a function of the committee members' clinical experience or personal experience. Now, another issue with abnormal psychology, with mental disorders, is the issue of labeling. That when we have a label like attention deficit disorder or major depression, and certainly there's a diagnosis like schizophrenia, that each of these diagnoses have certain associations with them, associations which have certain connotations, alrighty? For example, connotate with schizophrenia, a connotation of dangerousness or violent behavior, alrighty? And that diagnoses can stigmatize individuals. So for example, someone is diagnosed with a depressive disorder, that the stigma may be that the person is not responsible for themselves, right? Is lazy or is particularly, or is immoral. All kinds of negative, unjustifiable negative associations have been associated with different mental disorders, all right, stigmatizing those individuals. And it's no small cost when someone is stigmatized along those lines, in terms of social loss costs as well as occupational, financial costs. Alrighty. The other concern with labeling is that it may perform as kind of self-fulfilling prophecy. So if a child who may be rambunctious in the classroom, having a little difficulty staying in the chair, right? Now, is ADHD a legitimate mental disorder diagnosis? Yes, it is, in the sense that it is in the books, and there are some individuals who do suffer from really significant difficulties in attention and hyperactivity. That said, some people, there are also many individuals who are diagnosed with ADHD who probably are not suffering from ADHD. That their rambunctious hyper behavior may be just more of a function of poor structure, maybe low or poor parenting skills on the part of the child's parent, and that the behaviors demonstrated are part of normal childhood, which could be easily modified. But if a child who fits this kind of situation is diagnosed with ADHD, they, knowing that they're diagnosed as such, may behave in a manner, that kind of fulfills that belief. If they're called that you're a hyper child, you're ADHD, that if they're not on medication, they behave in a way that fits with their belief or their schema, as we had discussed in a previous chapter. But another strength of the Diagnostic and Statistical Manual is that it has also helped us to have a greater appreciation of the neurological component underlying psychological disorders. In other words, it reminds us that anything psychological is also biological. It's not either or, all right? It's a matter of how the two interact. Okay, let me stop here and take a little, let's pause for a moment. Okay, thank you for that moment, and let's continue. Okay, so let's look at the first category of disorders, anxiety disorders. Okay, there are several, well, let me take a step back. What characterizes an anxiety disorder? An anxiety disorder is characterized by a sense of distress, experience of distress, persistent anxiety or maladaptive behavior to reduce that anxiety. Okay, so it's about feeling afraid, nervous, and so on in different kinds of situations. Alrighty, and having difficulty reducing that. Alrighty, it's a part of human nature to feel anxious and nervous. All right, and it's all on a continuum. But certainly, there are some of us who may experience it to a greater extent, greater severity. Alrighty, and have difficulty kind of managing that. Alrighty, so let's look at some of the major diagnoses in this category. The first is generalized anxiety disorder. And this is where someone is feeling nervous or anxious about almost everything, all right? Work and school, relationships, finances, politics, and so on. All righty. And it's fairly persistent. All righty. And as an aside, it's probably one of the most common diagnoses among college students who report to a counseling, university counseling centers. All righty. Um, so it's just kind of general kind of anxiety and fear and nervousness that one feels through most of the day, on most days, on with various things. Yeah, it can be quite an unpleasant um, disorder to experience. The other is panic disorder. Now, panic disorder is characterized by individuals who experience panic attacks. Now, panic attacks typically can occur either daily, yeah, or once every few or several days, and so on. And when people experience panic attacks, it's usually something that lasts for maybe about 20, 30 minutes. Okay, so not super long. However, super distressing. All righty. It's a kind of intense anxiety where the person feels like they're going to die. They're so anxious, they're so scared. They typically experience a very rapid increase in rapid heart rate. They burst out into a cold sweat, and they feel the physiological experience of anxiety so intensely that it's not uncommon for people who have panic attacks to feel that that they're going to have a heart attack. Yeah, and it's not uncommon that people have panic attacks report themselves into emergency rooms out of fear that they're experiencing some kind of a medical condition. I mean, they are. I mean, in a sense that panic disorder is a psychiatric condition, meaning it's a medical condition. Alrighty, but in the sense that they feel like they're having a heart attack and that their heart is going to give out. Alrighty. Um, Let's see. But panic disorder, the good news is that it's very treatable. Yeah, with cognitive behavioral therapy, which gets at modifying attitudes and beliefs related and behaviors um, related to the panic attacks. Yeah, it's a kind of disorder which is very amenable to psychological treatment that lasts anywhere from maybe once a week treatment for about 3 to 4 months. Yeah, and most people tend to it can be very effective in decreasing panic attacks. It usually never completely removes the panic attacks from ever occurring, but when they do occur, the individual is better positioned to manage the anxiety. Yeah, through relaxation techniques, things they can say to themselves, be different behavioral things that they can do. Right, uh, take a walk, relax muscles in a certain sequence, and so on. Alrighty. I've had students tell me they suffer from panic disorder, and they also tell me that they, still experiencing. They've had treatment. It's been effective, but that occasionally the panic attack still occurs, but it's not anywhere near as intense. And also, there are ways that they can manage it. Yeah, I had a very bright student in class tell me ahead of time that he suffers from panic attacks and that he may leave the room in the middle of a lecture just to get up and go for about several minutes because what he needs to do is he has to sit out in the hall and kind of do some deep breathing, deep muscle relaxation to kind of calm himself down. That he can sometimes do it in the lecture room. So sometimes if he's like looking down, it's not that he's sleeping, but he's actually doing some of the behavioral work to manage or reduce the anxiety. Okay. Agoraphobia is a fear of being, just very simply, is a fear of being out of the apartment or home. Alrighty, it's a fear of the outdoors. Okay? But very specifically, it's about being fear or anxiety about being in open spaces, like in a big mall or an open parking lot, and so on. Okay. The fear very commonly is about related to the open spaces. It's the agoraphobia, by the way, just to take a step back, the term comes from a fear of the agora or the marketplace. You know, the idea that being in a public open space is fear inducing. Yeah, and very typically for those who suffer from agoraphobia, the anxiety is about being in an open space and losing control. Yeah, very commonly a panic attack. Yeah, and that if that happens, that they will make a fool of themselves, they will embarrass themselves, or something otherwise dangerous or bad will happen to them. Okay. That's why panic disorder and agoraphobia very often go hand in hand. Yeah, someone may be initially experiencing a panic disorder, and then it kind of develops into agoraphobia, where because they suffered from a panic attack out in public, the individual now has a very strong, persistent fear of leaving their apartment or their home. One thing as an aside, those who suffer from agoraphobia very often are able to leave the home or apartment if they do so with a friend or family member. Yeah, and if they are present out in public with the friend or family member. Yeah, so very often, and it's because the idea that if something happens, they know that they have someone that they can rely on, that they are not by themselves. All right. Just like panic disorder or agoraphobia is very amenable to cognitive behavioral treatment. Okay. Now, phobias we spoke about earlier, it's where there's a focus of anxiety on a specific object. Okay, like fear of dogs or fear of heights. Yeah, fear of being in enclosed spaces like an elevator. Alrighty. Phobias are fairly common. Anywhere between 7 to 10% of the population suffers from a phobia. But phobias are one of the least treated um, disorders. And because people rarely seek treatment for their phobias, because they manage it by just avoiding the phobic stimulus. Alrighty, so if they have a fear of heights, they avoid heights. If they have fear of dogs, they avoid dogs. And most people go, there you go, I've solved it. So most people don't treat it. When they do treat it, it's when the stimulus, the thing that brings about the phobia, be it the dog or the height, is just unavoidable now. Yeah, maybe they're in a work situation where they have to be in an elevator, right? Because their job is on the 40th floor and they can't scale the stairs anymore. Okay, then they might seek treatment. But phobias, just like, and as a general matter, most of the anxiety disorders, most if not all, highly treatable. Yeah, we're not talking long-term treatment. Again, anywhere from a few to several months of once week psychotherapy. Yeah, so phobias are very treatable. Finally, obsessive compulsive disorder is another anxiety disorder. Many of you probably have heard of OCD. OCD is characterized by an obsessive thinking um, or focus on some negative idea. Yeah, it's often a negative idea that provokes a lot of anxiety. Yeah, so maybe obsession about germs, that there are germs on their hands and that they'll get sick. Yeah, but some of the other obsessive thoughts may be very bizarre in nature, experienced by the individual as bizarre and just objectively kind of odd. Yeah, for example, an obsession about cracks in the sidewalk, and if they step on a crack, that something bad's going to happen. You know, it's like the old adage, you know, the old childhood adage, step on a crack, break your mother's neck. There are people actually obsessed on that idea. Alrighty. For some, it may be lines in carpeting that they need to avoid stepping on. Otherwise, something bad's going to happen. Oh, excuse me. And these obsessive thoughts are usually related to compulsive behaviors, yeah, behaviors that distract or take away the anxiety. So if there's an obsession about germs, yeah, compulsive behavior might be hand washing. All right. I once had an outpatient when I was in graduate school who had OCD for hand washing, and she would wash her hands about 87 times a day. And it was really bad because what happens if you wash your hand 87 times a day? You're going to have chafing, right? It's going to dry the skin and the skin's going to peel off. And it was really hard to see her sometimes because her hands literally, I could see had, she had band-aids on her hands because she had these wounds that arose as a function of the washing of her hands several dozens of times a day. Okay. Which is kind of the irony is that she had these obsessions about germs on her hands, but now she was washing her hands so much, she was actually making herself more susceptible to infections because of all these wounds that were appearing because her skin was peeling. Yeah. OCD can be very painful, distressful condition to experience, but again, very treatable. Okay, we'll bypass this. I'll just to kind of defer to your um, reading in the text. Yeah. So next we will discuss mood disorders, but let me stop here for a break. Okay, everyone. Thank you for that short break. Let me pull up my screen here and let's continue. All righty. So on mood disorders, next category of mental disorders. Um, Mood disorders could include, well, no big surprise, the disorders concerning mood, particularly depression. Yeah. And also the type of depression which is characterized by shifts in elevated mood and depressed mood, yeah, going up and down, or bipolar disorder. Now, there are several types of mood disorders or diagnoses in the mood category, but I'm just going to focus in on some of the more common ones, yeah, which include, first of all, major depressive disorder. Now, when we're talking about major depressive disorder, we're talking more than just, the usual blues or feeling sad or bummed out. Now, feeling sad is certainly natural and normal after, let's say, ending of a relationship or death of a loved one. What we're concerned about here are the kinds of severe depression which can affect social and occupational functioning. Yeah, so we're talking about not only depressed mood, but also feeling hopeless, you know, physical symptoms like decrease in energy, having difficulty waking up in the morning, or difficulty with sleep in general, and either the gain or loss of weight, yeah, because of changes in eating. Um, so those are the kinds of symptoms which characterize a depression. Yeah. Again, loss of a loved one or relationship, will bring on sadness. And, sometimes the sadness that takes a long time to get over, but not necessarily characterized by some of the other things I just mentioned. Yeah, not so much. Maybe some disturbance with sleep, but not the kind of thing where you can't get up and go to work. Yeah, feeling sad, but not feeling hopeless. Yeah, even though one loses a family member or romantic relationship, one doesn't necessarily feel that, they won't go on or they can't go on. Yeah, so we're talking about this kind of really severe depression, okay, beyond the everyday blues or the natural, understandable sadness that comes with other situations. Alrighty. So a major depressive disorder has to consist of several of these types of symptoms, and they need to last for a 2-week period or more. Alrighty. What's particularly concerning, as I mentioned before, is a symptom of hopelessness. Okay. Now, someone can be suffering from a major depressive or disorder and not have hopelessness, but if you see hopelessness, the idea that things will not change, either with work or school or relationships. Yeah, that's the real concern with that is that that's really closely related to suicide. Yeah, so you want to look out for if you hear something of that sort. Okay. Also, as a general matter, whether it's major depressive disorder or any of the other mood disorders, a mood disorder is generally correlated with suicide. That doesn't mean there's always suicide, but there is a higher probability of suicidal thoughts when one is suffering from a mood disorder. So it behooves the psychologist or anyone really, when they get a sense that someone is suffering from a mood disorder, that they should always assess or ask about suicide. Yeah. Not that it will necessarily be there, and not that there's necessarily an imminent risk of it happening, but it really does go hand in hand. Suicidal thoughts go hand in hand with mood disorders. Now, bipolar disorder, as many of you have maybe heard about, is a type of mood disorder, but it's elevated not only by depressed mood, but by elevated periods of elation, being super happy, unusually, inordinately happy. Yeah. And some of the characteristics will include things like a super elevated sense of self-confidence. Now, it's always good to feel confident and have high self-esteem. What's concerning is if your confidence is beyond the norm, the kind of confidence where you think how to solve the world's problems and you're the one to do it. That's a little extreme, little out of touch with reality for most of us, right? Um, and probably all of us, really, when you come down to it, there's no one person that saves the world. All righty. And also in its extreme form, the elevated mood may be associated with psychotic symptoms like hallucinations or paranoia. And we're not talking about just being concerned, the kind of paranoia where you're concerned about how others may be feeling about you, but really like psychotic level paranoia where someone might believe that the government is after them or the KGB is after them or something of that sort. Yeah, as well as, again, as I mentioned, hallucinations. Alrighty. So besides the elevated mood may be, as kind of touched on just a moment ago, grandiosity. Yeah. So delusions of grandeur. Yeah, that like I'm going to serve, like believing you're the one who's going to solve the world's problems. All right. But what's also concerning is just those periods, and the periods between elevation and depressed mood can last anywhere between a couple of weeks to, excuse me, maybe a couple months. Yeah, usually not much longer than that. But what's particularly concerning is as high as the highs are, the lows are equally low, okay, or equally in the opposite direction. And can also, as mentioned before, be associated with suicidal thoughts, or behaviors. Let me kind of move here. Now, what are the causes of depression? Well, there's certainly there's a biological basis for many of these disorders, if not all the disorders when you really come down to it. But clearly there are some biological causes or contributors to mood disorders. Many studies show that there's a genetic component. It runs in families. And also oddly enough, suicide does too. Yeah. So families that have had a history of family members who committed suicide, those families tend to be at higher risk, um, surviving family members at higher risk for suicide than individuals and families that don't have that history. In terms of neurotransmitters, the ones usually implicated are norepinephrine and serotonin. Okay. Norepinephrine tends to be low in those suffering from things like diagnoses like major depressive disorder, and it tends to be particularly high in those suffering from bipolar disorder. Is associated with the manic phase of bipolar disorder. Serotonin tends to be low in those suffering from depression. And as you may recall from prior discussion, serotonin tends to be associated with things such as sleep, eating, sexual behavior, and so on. So maybe no big surprise that when there's a low presence of serotonin, we start seeing problems in areas of depression like sleeping, eating, energy, sexual drive, and so on. Now, there have been for decades now, since the 1950s, a number of medications, antidepressants, which can be incredibly effective in treating depression. Some of the more current ones you hear about, their trade names have trade names like Prozac, Zoloft, Paxil. And they usually work not so much in producing more serotonin, but by blocking the reuptake of these transmitters or blocking the chemical breakdown of these neurotransmitters. Yeah, so not so much producing more serotonin, but keeping it in there in that synaptic gap, so that the other neurons can, pick up on that chemical, absorb that chemical. Yeah. Um, the thing that can be very tricky with antidepressants, sometimes patients are lucky enough, and with the first type of medication and first dosage, they're fine. But it's probably more common, and I don't know if we have good numbers on just how common, but it's probably it's fair to describe that the journey to figuring out the right medication and the right dosage, antidepressant to treat one's antidepressant to treat one's depression, is usually kind of a journey that might take months for many people to figure out exactly which medication and what dosage. And that can be kind of a frustrating experience for the patient as they kind of struggle with side effects like dry mouth, interruption with appetite, and so on. Yeah, mood being maybe shifting a little more than previously. There are also clearly psychological variables associated with depression. Yeah, there's certain group of attitudes and beliefs that depressed people tend to think of more, and through cognitive behavioral therapy, yeah, can work towards modifying, yeah, to change, modify their beliefs to make it their beliefs more adaptive. Yeah, it may be in terms of how they perceive reality, or even if their maybe their perception of reality is accurate, how they think about that reality, yeah, in terms of things such as how they think about themselves, the world, and the future. Depression psychologically can also be uh, eh, a function of this kind of psychological vicious cycle. Yeah, where someone experiences some bad events. First of all, when something bad happens, like we get a bad grade, or a boyfriend or girlfriend breaks up with us, right? We become very self-focused, understandably, right? Because we're hurting, so that kind of pain, emotional pain, kind of leads us to focus in on ourselves, right? Like, what did I do wrong? What could I have done better? And sometimes that self-focus leads some of us, right, to self-blaming, self-punishment, all that kind of stuff. And the more we punish, and some of us are just very good at punishing ourselves, blaming ourselves, or condemning ourselves. And people vary, right? And why people vary could be a combination of reasons, maybe a biological predisposition to do so. Right, a biological predisposition to get into a more depressed mood, which then kind of makes it easier to be more self-focused and then start thinking about more self-punishing, self-condemning kinds of things, which then makes it harder to change our circumstances, right? To study, to work, to go out with friends, to meet new people romantically. And then when we don't do those things, logically, we don't get positive stuff happening, like a better grade or meeting somebody else. And then that just leads to this vicious cycle of feeling depressed, and it affecting how we think of ourselves and then how we act, and so on and so on. Yeah, so sometimes part of the work is in terms of trying to break that cycle, either in terms of modifying one's beliefs, usually a combination of modifying one's beliefs and also helping coach the person to do things differently. Okay, here's a kind of a litany of facts regarding the prevalence and the severity of suicide. I'm just going to kind of go through this, bypass this. Um, so on the nature of suicide, yeah, one of the things to keep in, it's certainly incredibly serious. We have tens of thousands of people die every year from suicide, and tens of thousands more who attempt suicide every year. And what's particularly concerning is that in the last several years, the rates of suicide have increased incredibly for those in Generation Z, those born in 1995 and onward. Yeah, and we've seen about anywhere between a 30 to a 70% increase in suicides, not just attempts, but commission of suicide. Yeah, people kill themselves. The rates have increased. Yeah. Now I'm saying the rates have increased by 30 or 70%. I'm not saying 70% of those in that generation have committed suicide. It's the rates have increased of those who attempt, but also those who commit. Okay, quite concerning, and that's one of the things research is really trying to investigate the causes of that. Yeah, and I think we kind of discussed some of that maybe earlier this semester. Righty. In terms of attempts, women attempt suicide more, about three times more than men do, but men kill themselves, commit suicide 4 times more than women. Yeah, we can talk later when we meet face to face about why that may be the case. Yeah. Now, suicide tends to increase. You rarely see it in children. Alrighty, what you start seeing it increase in about adolescence, and then it really starts getting much higher in young adulthood and and for middle-aged people. Okay, it starts tapering off around the middle-age period, but then and then starts and only really starts increasing between 65 to 85. Yeah. So contrary to the stereotype, it's not that adolescents commit suicide more than, let's say, young adults or middle-aged people. Yeah. But what's concerning is that that's when we usually start seeing an increase. And as I mentioned before, we've seen this really striking increase between the ages of for Generation Z. Yeah. Here's some data regarding suicide rates between whites and non-whites. Yeah, kind of interesting data. And for each age group, yeah, we see a really striking difference between 65 and 85 uh, for whites between non-whites. And we can discuss this when we meet face to face. And in the total population, yeah, we can see that here. Data from 2003, from 1950 to 2001, yeah, the increase in adolescent suicide, yeah, it really started spiking up in the 60s. Yeah, it was almost non-existent. Yeah, but here spiking up. And then, but the other thing, as I mentioned before, is since around 2006, we've seen another increase. Okay, so quite concerning. And here is the suicide rate for the total population per capita. So number of suicides per 100,000. So why is that the case? Again, we can chat about this the next time we meet face to face. In terms of assessing suicide, this is something we'll discuss when we meet face to face. But anytime someone's depressed, you should always you should ask. Yeah, if certainly as a clinician, if someone is diagnosable as suffering from a mood disorder, you should ask about suicide. As a non-clinician, you probably don't have to. But if they're depressed and they demonstrate some signs of suicidal thoughts, you should ask. Okay, what are signs of suicidal thinking or behavior? We can chat about that when we meet face to face. Yeah, but if they are demonstrating some of those behaviors, you should ask. All right, and just simply ask someone if they're having thoughts of killing themselves. Right? If they're not, they'll tell you. All right, it's not likely that someone's going to get angry at you. All right, you cared to ask. All righty, but if they are thinking that, it's actually a big relief when you directly ask if they're having the thoughts. And the reason, and it's a relief, big relief for them, because what you're communicating when you ask things directly like that, just simply ask, are you having thoughts of killing yourself? You're telling that, but the meta communication is that you can deal with it, right? You can talk about that with them. Okay, I'm not saying be their therapist, but right, you can discuss with them where they're at and what may need to be done. All righty, and part of that discussion is finding out what kinds of thoughts they're having, if they have any intent to act on those thoughts, right? Because they may have thoughts but no intention. And also, do they have any specific plan? Okay, The more you have each of these components, yeah, the higher the risk. And the thing you want to look out for is if they're at imminent risk of committing suicide. Imminent meaning they could do it at any moment. Yeah. And a lot of this stuff we'll chat more about when we meet face to face. All right. Other things to to ask about is if they have access to weapons, particularly a gun. And this is not a gun control issue. This is just a fact. The fact is, many suicides are committed by use of a gun, and if one is present, the increased risk of something happening, the risk of something happening increases substantially. All righty. You want to find out if they've had any history of suicide attempts, and also what their living situation is. You have to live alone versus with others. If it's in the former, the risk increases. If they live with others, well, keep an eye on them, the risk decreases. Okay, but we'll talk about this a little further when we meet face to face. All righty then. The diagnosis of schizophrenia. Now, schizophrenia is a category on its own, and there are different types of diagnoses. Okay, just give me a moment. Time for a little Red Bull break. And by the way, we're not getting into the category of substances in substance abuse, and leave me alone. Yummy. Okay. Now, schizophrenia, yeah, the diagnosis, and it's a category, but there are also different types of schizophrenia. Generally, in terms of the diagnosis itself, yeah, you see it's characterized by numerous problems. Yeah, we see problems in thinking, problems in mood, problems with behavior. Yeah, it's just it's a real big mess psychiatrically. Yeah, because you have things that are problematic in a number of arenas. Yeah, not just mood, not just thinking, and not just behavior. Yeah, and it's pretty clear the genetic contribution to schizophrenia, and it's pretty clear that there are a number of areas of the brain that show pathology, which is related to the symptoms of schizophrenia. Okay, what are some of the hallmark symptoms of schizophrenia? First of all, disorganized thinking. Yeah, this includes a number of things, number of problems with thinking. Schizophrenia may be characterized by delusions, right? A delusion is a belief system which is rigid and which is not modifiable or amenable to change. Alrighty, a delusion might be a paranoid delusion, like believing that you're a space alien, or you're being followed by the KGB because you have the cure to cancer, stuff like that. Odd beliefs, very typically, usually paranoid, but there can be other types of delusions as well. Yeah. It's also interesting enough associated with problems with attention. Yeah, so those who suffer from schizophrenia, and this actually gets short shrift, this particular problem, often have difficulty attending to conversation and so on. Yeah, they seem to be easily distracted. They also seem to have difficulty clearing working memory. So once they get something in their head, sometimes it's very hard for them to take in new information. And it's also characterized by something called a thought disorder. Now, a thought disorder is characterized by breakdown into logical, normally not logical connections between different ideas. Yeah, kind of as you're listening to me talk about schizophrenia, right? Well, part of it is I'm being helped by the handy dandy PowerPoint here, but I'm connecting one idea to the next. Every sentence is related to the other. Yeah, and that's how we converse and think normally. Well, schizophrenia is associated with a symptom called thought disorder, which is generally characterized by breakdown in that. Yeah, so you'll find someone with thought disorder may jump from one idea to the other. Yeah, in the middle of a sentence might switch to another idea or combine ideas into a single sentence that doesn't make sense. Um, and it becomes very difficult to understand someone suffering from schizophrenia. Yeah, sometimes you might refer to some of this odd speech as like gibberish. Alrighty, and so you can imagine just how potentially painful that is emotionally to have a breakdown. And that's very commonly reported by those suffering from schizophrenia who can report their suffering, that they'll report just how frightening it is that their thinking is so disconnected. Yeah. Schizophrenia is also characterized by a symptom of by hallucinations. Now, hallucinations refer to a breakdown in how, in terms a disturbance in sensation, okay, in terms of what we see and hear, and touch and smell and taste. Okay, the most common the most common hallucinations are auditory. Yeah, like hearing voices. Um, and seeing things. That's another very common one. Okay, visual hallucinations. You can also have tactile hallucinations where those who are suffering from schizophrenia um, feel physical sensations that aren't there, like feeling like there are bugs under their skin. Okay, and so on, or eels or worms in their stomach, and there are no eels or worms or bugs under their skin, but they feel that. Alrighty, you can imagine how horrific that is. You can also have olfactory hallucinations where they smell things um, that aren't occurring. Like they'll say they smell feces everywhere, you know, um, but that's not the. But there are no feces everywhere. But they believe that's what they experience. So again, you can imagine just how horrific that can be. Yeah, hearing voices, seeing things, tactile, olfactory sensation, hallucinations. You rarely hear of uh, gustatory hallucinations, people tasting things that shouldn't be the case. But again, the most common are visual and auditory. Okay. The other thing is a breakdown in emotional functioning. And in particular, one of the things that's a hallmark of schizophrenia are experiencing emotions kind of in a very erratic manner, yeah, or in an inappropriate manner. So, for example, someone might hear that their mother died and then break out laughing, yeah, or hear a joke and then be enraged, yeah, and not because they were put off by the joke, but that it makes them think of something that enrages them. Yeah, so the kind of thing where you see a breakdown in terms of um, uh, the association of stimuli with emotions. Yeah, the emotions seem to be disconnected. Yeah, and not having that connection with the environment or what's going on. Yeah, and also a breakdown in managing emotions. Yeah, um, so in terms of modulating their feelings, right? So instead of feeling a little sad, it might be like being incredibly um, uh, depressed and so on about something that would normally bring on sadness, but then completely feeling besides themselves and depressed in depression. Okay, so whole bunch of things you can see that, and the reason why is that it's probably affecting a number of different. We know that in those suffering from schizophrenia, that a number of areas of the brain can be affected. So you see behavior, it's like a complete like breakdown. It's like everything's going wrong in the car. Yeah, the dashboard, the engine, the way you get the fuel into the tank. It's like everything's like broken uh, in someone suffering from schizophrenia. Here are some artwork done by those suffering from schizophrenia, which might give us a little window into the experience of some individuals experiencing schizophrenia. Example of thought disorder, which we can maybe spend a little more time with when we meet face to face. Now, we'll talk about this maybe perhaps when we meet. Now, what kinds of brain abnormalities are common in schizophrenia? Excuse me. Well, there's certainly evidence of dopamine overactivity. Yeah. And dopamine is involved in learning, memory, emotional regulation, the experience of reinforcement, yeah, reward. So a whole bunch of things. And it's also still associated with low frontal lobe activity. Yeah. And as you may recall, the frontal lobe is associated with organization, planning, and so on. Yeah. Also impulse control, which can be a common symptom or problem of schizophrenia. All right. In those suffering and impulse control concerns, being able to handle um, what you do when you're feeling hungry or sleepy or having a sexual feeling, right? We all kind of learn from childhood how to manage those things, right? That if you feel like you have the impulse to use the bathroom, right? We learn how to use the bathroom. Or if you're feeling hungry, right? You don't just grab a donut. Maybe a toddler might, but we learn you just can't grab the donut in the bakery without paying for it, right? But that ability to control our impulses, right, manage our emotions, similarly related, is more problematic in those suffering from schizophrenia. Those suffering from schizophrenia also seem to have enlarged ventricles in their brains, and the ventricles are like this area of space that go from the front to the back of the brain. And here's like an illustration of normal ventricles versus enlarged ventricles. Okay? And how does this contribute to schizophrenia? It may not be the ventricles per se, but when they're enlarged, yeah, the amount of white matter that may be lost, yeah, as a function of the fact that now there's more space here. Okay, so that's a possible relation between enlarged ventricles and schizophrenia. Also, there are a lot of studies to show that those who suffer from schizophrenia may have actually been, fetuses that were exposed to viral infections. Yeah, so maybe in either the second or first or second trimester, the embryo or fetus was exposed to, let's say, something like the measles, or the mother was exposed to the measles or some other viral infection, and that these infections may have contributed to, abnormalities in brain development, leading to schizophrenia. There's certainly a lot of research to show a genetic contribution to schizophrenia. It tends to run in families. Twin studies, adoption studies show a genetic contribution. The closer the degree of familial relationship, the higher the probability of, suffering from schizophrenia. So in the general population, 1% of people suffer from schizophrenia. And if it's a first cousin with schizophrenia, there's a 2% probability. If, let's see, uncle and aunt about the same. And let's see, if the parents suffer from schizophrenia, there's a 6% chance of suffering from schizophrenia, and so on. Okay. Oh, I'm sorry. With the parents, if the individual is suffering from schizophrenia, there's a 6% chance that one of the parents suffers from schizophrenia. Okay. And certainly there are psychological factors. Yeah. Because if you look at the MZ twin kind of findings, yeah, the identical twins who have essentially the same genetic code, right? There's only a 48% concordance rate, meaning that there are 52% of identical twins who don't demonstrate schizophrenia. Okay, so why might that be the case? Yeah, it may be even though they have the same genetic potential, right, code for the disorder. For one twin, that code was initiated, right, was switched on, whereas for another twin, it was not. And what turns on the genetic code for one twin and not another may have been something that occurred in the prenatal environment, exposure to maybe greater exposure to a virus, perhaps, or some maybe physical occurrence, Yeah, maybe there was some kind of physical trauma that affected one side of the pregnancy versus another, physically, literally, right? Just as you can be struck harder on one side of the head versus the other. Maybe if the pregnant mother was in some kind of a physical um, uh, kind of accident, and which affected one side of the womb versus the other. Yeah, or it could have been something postnatal, some kind of trauma that occurred to one twin versus the other, which set off the genetic code. Yeah, switched on the genetic code for schizophrenia. It can happen with other kinds of things, heart disease, cancers, and it can certainly occur with psychiatric conditions. Okay, I'm going to bypass personality disorders. And if we have time, we'll get into the sexual disorders. All righty. But with that, I'm going to stop here with the YouTube video. And with that, thanks for your time and attention as usual. And I will otherwise see you later. Take care. Oh, but this will be the last of our YouTube video lectures. All righty. So with that, thank you for your attention this whole semester on the YouTube video lectures. We still will be meeting through the semester and so on. But as far as the YouTube lectures, this is it. So take care, and I'll see you later. Bye-bye.